talk a lot about provider status. So APHA is really focused on provider status, although I think there's another term for it. This is where I should have done my research before the podcast.
Is there some rebranding?
I think there might be a rebranded term, but and not because it's more than just provider status. It's about health plans recognizing pharmacists as providers. Really, that's what it means. Just like dentists and other healthcare providers. And then that opens up the billing. That opens up the or helps to solve for the problem of how do we pay pharmacists? Because that's our big I can't even tell you. So through Flip the Pharmacy, so our practice transformation team in Pennsylvania has formed a Flip the Pharmacy payer advisory group. And we meet quarterly with this payer advisory group. There are colleagues in from different health plans and different payer entities across the state. And, they're with us. They're right there with us. Most of them are pharmacists. They're like, we get this, but what we can't figure out is the how to pay pharmacists for services when you're not on this list. Yeah. Because we go to credentialing and you're not on this list, so you don't fit into this bucket. So sorry, it doesn't work. And that's where I think a lot of the efforts from APHA and from the state pharmacy associations is going to be really, focused on. We're learning from Ohio. We're learning from Washington Pharmacy Association. We just met with them yesterday, actually, to learn about, how they did it. What's the trick? What do we need to know? What can we learn from them?
Well, it's interesting, like Washington did this a while back, and the number of pharmacist providers in the state is still really, really low. Like under 1% of pharmacists are like billing for services. Now, the ones that are doing great stuff, right? Like your oral contraceptives, your, diabetes education, things like that. But it's still really, really low.
Is that because the barrier to entry is high? Is that what it is?
What is that barrier to entry?
Well, you have to get credentialed with every single
You have to have enough density or
a
market or addressable market probably to warrant the expense.
Right. Well, and even if you have one payer who figures out how to do it, you still have 50 where you have to go through every single one of those hoops and convince them, all right, look, I can really do this. Credential me. How do I credential? I don't know. And then, you have that other end where I think there are some groups that are focusing on it, but CMS really, as soon as they tie the pharmacist to be able to do work that counts toward MIPS and MACRA, it changes the game.
Yeah. How so?
Well, right now, if a pharmacist does work, you have a pharmacist in the community that drives all of your diabetic patients to the right therapy and the goals. The doctor doesn't get credit for that. And then their quality scores don't reflect their bonus. So they have to do the double work, and then the doctor gets paid for it. Which, if the doctor does the work, they should get paid, but it doesn't count both ways.
See,
it's hard to give credit to the actual individual or entity or the actual intervention. Like it's hard to pinpoint like what intervention actually caused that. But yeah, we're thinking about also if we want to be treated like a provider, then we have to act like a provider and get credentialed with every single health plan. And at the network level, so at this local CPSN network level, we're working with health plans to help manage that in kind of a roster type of format. If health plans are willing to participate with us, and that helps to take kind of like an ACO, right? Yeah. So it helps to take some of the burden off of, the individual provider. They still have to, give us the information. But it makes it a little bit more manageable from an onboarding standpoint. So I think that's kind of where we want to get to.
What are the not kind of shifting, but on CPSN, I know you're super involved, and I know vaccine efforts have been kind of top of mind for the most part, but you guys are fairly mature, or one of the more mature networks as far as like payer contracts in general, right?
That's correct. Yeah, so we for the past 4 years have worked closely with one health plan in particular. It's a Medicaid MCO, and our pharmacists were paid for providing comprehensive medication reviews for any patient with a chronic medication, pediatric to any age. So that was really cool to see pharmacists engaging with pediatric patients and helping them manage their asthma, for example, and then finding out that the parents smoke, and then working with the parents to help them to quit smoking. So it's like they were like treating the household as opposed to even just the individual patient, which was really cool to see. Now we currently have 2 payer programs launched with 2 different Medicaid MCOs in Pennsylvania where pharmacists are being paid to provide care for asthma, COPD, diabetes, and the eCare plan is the source of truth in verifying eligibility for payment in that. So we're working with CPSN to facilitate the billing, so to speak. I don't like saying an eCare plan is a bill. That's why I want to get this X12 in your pipeline. But that is the source of truth. It has to meet certain criteria to enable that care plan to be eligible for payment for the pharmacy. So we've had good success. Again, the health plans are, they see the value in it, and we need to demonstrate it through the care plan. So we're really, really reliant on health plans going to do their own analysis. Like they're going to look at the medical costs. They're going to look at all of that. But we're reliant on the data that we can get out of the health or out of the care plan to tell the story about what's really going on. Like that family that I just mentioned, they identified the child had uncontrolled asthma. Well, then they also talked to the parents about, other risk factors in the home, and were able to really take care of it. That's what is exciting. And, in the role that community pharmacists can play in identifying some of those things. So
why do you think you guys have been successful in doing that kind of development with payers where other CPSN networks may not have been yet?
She's like, it's all me.
She's all Stephanie McGrath, PharmD.
It's like right here.
We'll put some fingers pointing at you.
I heard this was a party, so I did invite a friend.
I love that.
This is a team. Like it is totally. I'm holding up for the viewers that maybe are just listening. Yes. Our Flip the Pharmacy Practice Transformation team was awarded Team of the Year for Cohort 1 for Flip the Pharmacy, which is awesome. And it's a team. And kudos to PioneerRx for being recognized as a technology solution partner of the year. You're part of our team. You're part of what has helped to make us successful. So thank you for your partnership in that. Josh literally coming out to, Josh was some of our boots on the ground coming out to Pennsylvania before everything shut down and helped to inspire and train our pharmacists. So it really is a team.